All right, we're back. We're still on schizophrenia, believe it or not. But a little review. This is how you diagnose it. This is what you need to rule out. That's delusions. This is hallucinations. This is disorganized thinking / speech. Remember, they're related. And this is disorganized abnormal motor behavior. And then you have your negative symptoms. Okay. And this is mentioning that schizophrenia has to cause disturbance in functioning areas. And these are the etiologies. Remember that it's high dopamine in mesolimbic, low dopamine in mesocortical, high glutamate, low serotonin, and low GABA. And this is the onset. And usually when it shows at an earlier stage, it has better prognosis. And this is how you diagnose it early or catch it early. All right, moving on to differential diagnoses. Think about it. For schizophrenia, there's epilepsy. It could be CNS neoplasm. It could be cancer, actually. It could be AIDS. It could be B12 deficiency. See, it could be a lot of things. It could be SLE. It could be neurosyphilis. It could be heavy metal poisoning. It could also be bipolar affective disorder. It could be substance-induced psychosis. So you always want to rule out substance abuse. It could be a mood disorder with psychotic features. Okay. It could be schizoaffective. It could be schizophreniform, which we will introduce. It could be just a brief psychotic disorder. It could be a delusion disorder. So you have to know all of these in order for you to know, oh my gosh, this patient really has schizophrenia, okay? So management might need hospitalization if there is concern for what? Safety. Don't forget about safety. Stabilize symptoms. Well, to stabilize symptoms and to monitor adherence to medications. Because if the patient is having psychotic symptoms and they're not taking their meds, that's a safety issue, you see? And then, so the first line is really atypical antipsychotics, okay? So now we're gonna say schizophrenia treatment. Finally, we made it to the treatment. That took forever. That last video was really long. I didn't realize it was gonna be this long. This one I'm gonna move on. I'm not gonna dwell too much. Maybe we'll see. All right. So the first line is AA. Okay, antipsychotic. No, atypical antipsychotics. And I have a chapter here, not a chapter, a Word document that I did before that has all the meds. Let me pull it really quick. This one. But I thought I just want to merge both of them into one because I don't want to go through two different Word documents. I just want to do. So it has, as you can see here, it has the typical ones, then it has the atypical antipsychotics, and then it has some notes about antipsychotics, And then it has EPS signs, which we're going to definitely have to go over and know, like the back of your hand, you have to know those. And NMS signs, you have to know NMS signs. So that's it for antipsychotics. So we're going to copy all this, and it's going to go right here. Okay. So the first line is atypical antipsychotics. So the typical ones, I'm moving them to a little bit further down because they are not the first line, okay? So here you go, atypical antipsychotic, aka second generation, SGA, second generation antipsychotics. Forget about this little whatever this is my mnemonic. It might help, it might not, I don't know. But these are your atypical antipsychotic. Clozapine, aka Clozaril. It's the only drug for treatment-resistant schizophrenia. The patient must enroll in REMS program. It can cause agranulocytosis, neutropenia. So the key here is you have to check the ANS levels, not the WBCs, and it has to be checked weekly for 6 months. You know how crazy that is to maintain or to adhere? Even a regular person who doesn't have schizophrenia, it's hard for them to show up every single week to get blood work for 6 months. You know, so think about how hard it is for a patient who's battling all these symptoms of schizophrenia to really remember to come once a week. And then you check it bi-weekly for another 6 months. Then you go monthly only if the ANC is normal. Now, if the ANC is less than 500, then you stop the medication, okay? So remember, less than 500, that's too low. Other signs, side effects of clozapine is NMS, myocarditis, seizure, diabetes, weight gain. Almost all of them have weight gain and diabetes. So almost all of the atypical, you're going to see the same thing, okay? DM, weight gain, monitor BMI and waist. Circumference, lipids, glucose. So that's why I added them all together, because they're going to show up a lot, these. The second medication to talk about is olanzapine, aka Zyprexa. This one, now you have a lot of weight gain. They even give it to patients with anorexia nervosa. So think about it. If injection is given, monitor. You got to keep the patients 3 hours post-injection, because to monitor them, because it can cause delirium sedation syndrome. It can cause obviously high weight, high LFT, and high prolactin. So a lot of highs here. And remember, your LFTs are your liver enzymes. Prolactin, that's what's going to cause the galactorrhea. I hope I said it right. Seroquel also hits your liver and can cause cataracts. Abilify is not bad because it's a partial agonist of D2 receptors, meaning it does not completely block dopamine. It keeps the door a bit open, so it's less likely to cause EPS and high, but it also causes high prolactin levels. Okay, so it's good that it doesn't cause a lot of EPS side effects, right? But it causes high prolactin levels, because every time you if it's a complete agonist, then it'll be different. But because it's partial agonist, that's why it keeps the door open a little bit, okay? It's less likely to cause metabolic syndrome, but some side effects are headaches, anxiety, agitation, insomnia, GI upset. Honestly, I stopped memorizing GI upset because every single medication can cause GI upset. So there's no point of memorizing. Like, you can say GI upset, you can say headache, you can say, what's the word, nausea, diarrhea, I don't know. They're just so common and non-specific to so many medications. So when I see GI upset, I really don't even focus on it, to be honest with you. You just focus on the big things here. So Abilify compared to the other, you just need to make sure you can see what makes this special. Why was it invented? So what makes it special is that it's a partial agonist. So that's why it has less EPS than the rest. Of course, high prolactin. but also less metabolic syndrome. And then we have this one. This is an Abilify in an injection form. So I did these notes a couple weeks ago. And so it's the same word, but it's called, okay, I'm not going to even try to say this, aripiprazole, loroxel. I have to learn how to say these words properly. The fancy name is Aristada. I would rather just say Aristada at this point. So this is Abilify in IM form. It's once a month. That's actually very convenient. Once a month. That's not bad. All right, Geodon, ziprasidone, less likely to cause metabolic syndrome. But the thing you got to remember here is the heart. You got to watch your QT interval because it causes QTC interval increase. So you got to monitor that. And don't give it with other drugs that do cause also QTC. Don't give it with patient with hypokalemia because remember how significant it is for potassium with the heart. Remember the relationship between those and the magnesium as well. Don't give it to patients who have had MI or CHF. And it can cause DRESS, which is drug reaction with eosinophilia and systemic symptoms. Okay, so just remember eosinophilia. All right, you got to take it with food. It can increase the absorption up to 2 times. All right, so remember to take this one with food. Risperidone, if the dose is higher than 6 milligram, it can increase the chances of EPS. It has the greatest prolactin elevation among all SGA. So this is the one you really want to tell your patient, like, look, might end up with galactorrhea. Okay. And watch for adherence because a lot of people might not want to take it anymore because of this. It also has an IM injection. But the big thing is galactorrhea. So let's save that. Okay. Geodon, the big thing I think is to take with food because I've had this show up in the chapter quizzes, and QTC. Actually, I think QTC is more important than take with food. But I'll highlight both. Abilify, it is less likely to cause EPS. That's important. And it's less likely to cause the metabolic syndrome. This is what makes it special. Olanzapine, it will definitely increase your weight and you need it for anorexia nervosa patients. So that's good. Clozapine is on another level. This one is really different. It's really special. It's easy to tell it apart. Then you have Invega, which is a injection also. It's either called Invega Sustina or Invega Trinza. And these are very common, by the way, when we're doing clinicals. A lot of patients are on them. So this is monthly. This one every 3 months, which is actually awesome. 3 months, that's amazing. That will increase adherence for sure and compliance. And by the way, this is an extended release risperidone. That's really what it is. The name is not that, well, it's kind of similar. Risperidone, this is paliperidone. So you get the ris and you get the pali. The pali is the injection and the risperidone is the pills. And then you get the Fanapt, which you have to titrate slowly, okay? Because it's an alpha-1 antagonist. So it causes vasodilation. So it's just like your typical blood pressure medication. Orthostatic hypotension. Then you have Latuda, which is a pill form. You got to take it with food. I think this is the main one that you got to take with food. Because I know there's one you have to take it with a lot of calories. And then you have Saffris. This can cause akathisia. Then you have Rexulti. This can cause akathisia and weight gain. Then you have Vraylar. This can cause EPSE symptoms and weight gain, of course. So these are your atypical antipsychotics. I don't know how we're going to remember all that. But I think what I tried to do here is I realized there's 4 pines. There's clozapine, olanzapine, quetapine. So there is 1, 2, 3. Where's the 4th one? 2, 3. How did I come up with 4 pines? Oh, and acinapine. Okay, so I realized there's 4 pines, and then I realized there's Abilify, which we all know. I mean, we should know Abilify. And then there's the knowns. Like, I'm done. So we have this one. So ziprasidone, that's your geodon. Then we have risperidone. Then we have paliperidone. Then we have iloperidone, which is the Fanapt. Then we have the loracidone, which is Latuda. Then you have these 2 that do not match the rest. The Zol and the Zyne. Oh gosh. Okay. Zols and Zynes. Which doesn't make any sense because it's only one of them. And Zol is antifungal medications anyway. So that doesn't help. But the exam is only about psych medications. So they're not going to put an antifungal. I hope so. So if you see a Zol, something that ends with this Zol, most likely it's your atypical antipsychotic. Or I hope so. I don't know. All right, typical antipsychotics. This is first generation, FGA. So this one here, these are the names. So you have Haldol, which is the highest potency. Okay, highest, it causes so much. Okay, it causes EPS, like for real. And then you have loxapine. So this is your HL. And then you get your Zynes. See what I mean? This one has a Zyne too. But it's atypical. But these are whole Zynes and they're typical. Okay, fine. It's not Zyne. It's cariprazine. So cariprazine is the only zine that's atypical. Okay, all the other Zynes are typical. Thorazine or zine, whatever, however you want to say it. You say however you like. Thorazine, thioridazine, fluphenazine, mesoridazine, trifluperazine, chlorpromazine. This is low potency. Okay, so this is high, this is low. And then we have the furfenazine. So this one, all right, so it says here, why is this by itself like that? So it says the high potency FGAs like Haldol, it can cause more EPS, the low potency like chlorpromazine, it can cause, now the problem with that, it can cause more anticholinergic effects. You see what I mean? So that's the problem with typical antipsychotics. They either cause too much EPS or they're going to cause too much anticholinergics. You see what I mean? So you don't win. You don't really win that much in this case. Sorry that. OCD is kicking in. Anywho, that's the antipsychotics. All right, so we're done with this, and then these are your typical. High potency cause more, low potency cause anticholinergic. What are the anticholinergic effects? Remember nursing school more than 10 years ago? Can't see, can't pee, can't spit, can't poop, can't think, because their ACH is too low. All right, and then we have notes about antipsychotic. We have all antipsychotics block dopamine and are used for schizophrenia, psychosis, bipolar disorder, and acute mania. So they're not just for schizophrenia. All right, second generation antipsychotic cause less EPS but more metabolic syndrome. Abilify and Geodyne have lowest risk of weight gain among the SGAs. For every SGA, you know what, I'm going to put this here. I don't like this sitting by itself. I like the ideas to be next to each other, you know. All right. Causeless. More anticholinergic. For every SGA that causes weight gain, you need to monitor serum glucose, lipids, BMI, waist, assess for personal or family history of cardiac disease. Okay, so all of them really. Now, EPS signs, these are important. I'm gonna kind of put them in one page here so we can see all of them. So EPS signs, we have side effects. EPS are really side effect of antipsychotics. So we have akathisia, and then we have akinesia. All right. Akathisia is AKA, it's restless, inability to sit still, pacing. You treat it with propranolol and clonidine. Akinesia, this is a Arabic mnemonic, actually. That's the only way I learned how to memorize it. So it says aki umitharaki, which means taraki means get up and move, right? So akinesia, they're not moving. Lack of movement. They feel lazy and unable to initiate movement. So you tell them, Aki, umitharaki, Aki, get up, let's move. Dystonia. Dystonia is painful muscle spasm, mostly on the back and the neck. Pseudo Parkinson's, that's mask-like appearance, which you guys know already from nursing school. Tardive dyskinesia, remember this one? It's irreversible. Abnormal movement of the mouth, tongue, face, jaw, lip smacking, chorea. And chorea is actually from choreography. That really helped because for a long time, like, I gotta look up what's the like where this word come from. And then I realized it's choreography. I didn't have to look it up. Anyway, how do you treat EPSE? So for all four, there's multiple medications for that. You get the Cogentin, right? Which is AKA benztropine, and then you get the Artane, and then you get the Chemedrine. These three can cover all four EPSs. Not tardive dyskinesia, though. Is tardive dyskinesia an EPSE? It's a very good question. Hold that thought for a sec. Okay, yes, it is. It's just the treatment of it is so different. So these first four medications, three medications, they're for 4 EPSs. And then you have Benadryl. See, this is too complicated here. For first 4 EPSs. Okay. All right, and then you get Benadryl for all but not akathisia, okay? And then you have propranolol and Inderal. This is for akathisia, okay? So Benadryl will do everything for you except akathisia, and then propranolol comes in and clonidine, and they can do akathisia. Focus on this one. Then you have clonazepam and lorazepam. These are your benzos. They're also options. And then you have amantadine. It's for Aki and for pseudo Parkinson's. Okay. Now for TD, to specifically treat this tardive dyskinesia, of course, the best thing you can do is prevention by careful monitoring. And if present, you have to lower the dose and change to the atypical agent. Well, change to an atypical agent. Now, the FDA approval for TD is these two very fancy words here. Ingrezza and Ostidio. They're like names of artists or something, like dancers. Like here come Ingrezza and here comes Ostidio, you know? They're gonna do tango or something. Like a female dancer Ingrezza and a guy Ostidio, you know. Anyway, these two, I hope they show up with their brand name because I can't memorize this yet. But I'll come back to this and memorize it more. It's just right now, these are kind of new information here. Anyway, NMS signs. So this is another side effect here you got to watch for. So NMS happens, think about it, when dopamine is blocked, is low. NMS can happen, and that's an emergency. So that's what you're going to give the patient. Okay, first you're going to send them to the emergency room, and then treat with IV hydration. Okay, cool. So these are the notes I've already taken before. Now there's some here that I might need to add because I was reading the purple book. All right, so watch atypical antipsychotic. They can treat both positive and negative symptoms of schizophrenia. Isn't that nice? Okay, they block both dopamine and serotonin. No, wait. All right, so that's kind of the difference. Typical, these they block dopamine. So again here, they're explaining in the book a little bit more about the dopamine pathways. So let me go back here. Remember this here? One of the causes of schizophrenia etiology is messed up dopamine. So what it's saying here, all right, mesolimbic. In mesolimbic pathways, second generation will block dopamine, which causes decrease in positive symptoms. Okay, so let's add this here. Okay, so in the mesolimbic pathways, okay, dopamine is usually high. Okay, in the mesocortical pathway, dopamine is usually low. All right. So in the etiology of schizophrenia, you got to know this in order to understand what are the antipsychotics really doing. So in the etiology of schizophrenia, the mesolimbic pathway dopamine, I didn't mean usually as in like it's normal, abnormally high, and here it's abnormally low, if that makes sense. So we need SGA, lowers dopamine in mesolimbic, and therefore decreases positive symptoms. You see what I mean? You need to know one thing here. High dopamine equals high positive symptoms of schizophrenia. Okay. And then you need to know high dopamine means low negative symptoms of schizophrenia. All right. So once you know these, I'm trying to figure out the highs and the lows. What's low? So when there's high dopamine, you have less negative symptoms. When you have high dopamine, also you have high positive symptoms. Also, by the way, when you have high dopamine, you're gonna have low prolactin. So by the way, that's why a lot of SGA, what they do is they lower the dopamine, which causes the prolactin to increase. That's why you end up with glycotorrhea. So you need to understand the inverse relationship between these in order to understand how SGA is working. Now, every time you have high dopamine, you have low ACH. Again, that's why when you give a patient the typical antipsychotic, it can cause anticholinergics because their ACH becomes so low, right? Because the dopamine, more anticholinergic effects. So that's what you see in FGAs in first generation. And then we have, when the dopamine is high, it can lead to low serotonin. So they're kind of inverse here. So SDA lowers serotonin, which therefore increase dopamine. Then it lowers ACH. And so it has lower EPSE. So that's why second generation antipsychotic has lower EPSE side effects, if that makes sense. Now here, the etiology of schizophrenia, in the mesolimbic pathways. In the mesolimbic pathways, I'm trying to say that this is a patient with schizophrenia. So pathway of patients with schizophrenia. The dopamine is abnormally high. And then in the oh my God, why am I spelling this wrong? Mesocortical pathway of patients with schizophrenia. The dopamine is abnormally low. So SGA here comes in, increased dopamine in the mesocortical, causing decrease in negative symptoms. It's a little bit confusing. But once you know that high dopamine is equal positive symptoms of schizophrenia, and when the dopamine is also still high, there's low negative symptoms of schizophrenia, okay? So it depends which pathway we're talking about. When the patient has schizophrenia, their mesolimbic pathways have abnormally high dopamine. So SGA comes and lowers it in the mesolimbic. So they decrease positive symptoms, because when you lower dopamine, you get rid of positive symptoms. But then in the mesocortical pathways, it does the opposite, because over there, patients with schizophrenia, their mesocortical pathways have abnormally low dopamine. So SGA comes in and increases dopamine, which causes a decrease in the negative symptoms. Okay, and SDA, where's my vocabularies? Let me tell you here, there's an interesting word here that the Purple Book has been using. SDA means serotonin, dopamine antagonist, which is also mean SGA, by the way, which is also mean second generation atypical antipsychotics, second generation. antipsychotic. But why do they call them SDA? Well, they're also called SGA, that's fine. But, see what I mean here? They call them SDA because they lower serotonin. Ow! They lower serotonin and dopamine. Okay, that's why they call them SDA. So if this shows up in the exam, now you know SDA is not like a new word that we don't know. We actually know what that means. Where was I going to put it? I lost my train of thoughts. Where was I trying to put this? Oh, right here. First line, they can be positive. They can be for positive and negative symptoms. They block both dopamine and serotonin, and they are AKA SDA. Okay. Okay, cool. Moving on. Okay, so cool. What else do I need to gather from this? Oh, there's another pathway. Great. There's 2 more pathways. You thought there's only 2 pathways, didn't you? Hilarious. It's just too funny. I'm tired of this. Okay, there we go. So, oh gosh. I just read it and it's very confusing. Okay, so the other one is called striatal pathway. Okay, this one, dopamine, has reciprocal relationship with ACH. That's why I put it here. See what I mean? When there's high dopamine, there's low ACH. You need to know these seesaws, okay? They're going to be very, very helpful when you're sitting on the test trying to figure out these questions. So SGA blocks. So when SGA blocks serotonin, dopamine increase. Because remember, serotonin and dopamine are also a seesaw, inverse, reciprocal. And then when dopamine increase, ACH decrease, okay? Which causes low EPS and high anticholinergic effects. So look at this. EPSE is caused by increased ACH. That's where it's coming from. It's all this craziness. Where is it? EPSE. Where's my EPSE? Caused by low ACH. That's all it is. It's just low ACH. When you mess up your ACH, it causes all that crap, right? But why did we mess up? Oh, sorry. Oh my God. Sorry. I messed it up. High ACH. EPS is caused by high ACH. Yeah. And how did that happen? Well, if you're curious, this is where it is. It's in this pathway. The dopamine has reciprocal relationship with ACH. It's because of this relationship. So there's high dopamine, which means there's low ACH, okay? Oh, sorry. Oh, just confusing myself. Okay. There. So listen to this. The only thing you really want to know here is that when serotonin is blocked by SDA, okay, so SDA, they block serotonin, which causes dopamine to increase, and then it causes ACH to decrease, which causes low EPS. Okay. I don't know where did I get this from. There you go. Low APS. So this is why SGAs are better than FGAs, because SGAs, they block both dopamine and serotonin. And when they block serotonin, the dopamine will increase in this pathway. Pay attention to that, which causes ACH decrease, which also causes low EPS. All right, last pathway. Tuberoinfundibular pathway. This one now, dopamine inhibits prolactin. Okay. So I think the pathway here is dopamine has reciprocal. I like to say dopamine and ACH are seesaw. That's what helps me remember, okay? Same with prolactin. Dopamine and prolactin are seesaw. You know, once I know these are my seesaws, then it's not that hard. You need to know your seesaws for schizophrenia. See what I mean? Just save them here, and then you just gotta remember them. That's all. The seesaws. Okay, so high dopamine, high positive symptoms. Let's just say more positive symptoms, less negative symptoms. And then seesaw, watch this high dopamine. It's really seesaw with all of these three, okay? Now, when there is low ACH, this is what I'm trying to not confuse myself with. EPS is caused by increased ACH. So when there is high ACH equal EPS present. Okay, low ACH, you get anticholinergic effects. Am I right? Did I get this right? Okay, sorry, I paused a little bit, then I added something. So, all right, we figured out the dopamine situation, that's fine. And then when it comes to ACH, high ACH, you'll start seeing EPS. And then when ACH is low, because of the anticholinergic drugs, which are the antipsychotics, then it can cause anticholinergic side effects. Okay. Lower serotonin. So increased dopamine, then it lowers ACH, and so it has lower EPS side effects. Sure, I'll leave this here. It's just a little bit confusing. All right. And then now we're gonna talk about schizophrenia. Please know your pathways. Okay. These are the pathways. So anyway, last pathway, dopamine and prolactin are seesaw. That's what you need to know. Do I have it here somewhere? Yes, right here. High dopamine equals low prolactin. Okay, so this is this pathway here. So what's going on here? The blockade of dopamine. All right, so SDA blocks dopamine. All right, causes prolactin to do what? Increase. And that's how you get galactorrhea. Okay? And gynecomastia. Okay, see what I mean? Sexual problem. Okay. So these are your pathways. So once you know your seesaws, this will make more sense. You know what I mean? Just know your seesaws and your pathways. Okay. So now when we're talking about these, you know why. It's because of the seesaws. For FGA, that goes green. Okay. All right. Let's make this kind of uniform. I hate when the fonts are not the same. It hurts my brain. It literally hurts my brain. Okay. So seesaw pathways. All right. So we talked about the EPS. We talked about the treatments. We talked about NMS. All right. What else? We have the typical antipsychotics. Talked about NMS. How do you treat it? All right. And then non-pharmacological management, of course, of schizophrenia. Well, how long is this video? 45. Okay. I think we can finish this chapter. Please, can I just finish this chapter? Oh my goodness. No, you can't, because then we're going to talk about Schizophreniform and all that. So anyway, all right, we did all this. We're going to watch all this. Let's put them all together. These are really important. Like, this chapter has a lot of information. And by the way, I'm just going to go through this table here. They have a table about those typicals. All right. I didn't really put these yet. So this one. Thorazine, that's the fancy name, is Thorazine. You know what, I'm gonna go ahead and put all the names here, and then I'll pause the video. I'll be back. All right, and we're back. So typical antipsychotic, they block dopamine. Side effect mostly is EPS and anticholinergic side effects. Haldol is high potency, very high EPSE, high sedation, high anticholinergic side effect. And in geriatric population, you gotta monitor for oculogyric crisis and pneumonia. For Thorazine, that's a low potency first generation antipsychotic. Side effect also sedation, hypotension, but also photosensitivity and allergic dermatitis. And then you have to monitor QTC, okay? So I put it under this one because these two are common, I guess. And then I put all the heart ones, the ones you got to watch the heart next to each other. So you got the Thorazine, and then you got Miloril, and then you got Serotonin. So these three, you got to watch the heart. These three. And almost all of them are the same. Look at this: anticholinergic, sedation, high EPS, very high EPS, sedation, hypotension, high EPS, blah, blah, like they're all the same. So I left the bottom ones, they all look the same to me, honestly. But the first kind of four, they look a little bit different. But that's your typical. You're not going to see them a lot. So let's go a little bit here just to reiterate. So schizophrenia treatment, we did atypical antipsychotics. And then we did more here. Okay. And then typical antipsychotic, we just did. And then notes about antipsychotic, that's what I was explaining earlier. And then you have your seesaws. And then you have your pathways. Okay. Then you have your EPS. That's your EPSs. And how do you treat each one? And then you have NMS. This happens when the dopamine is low. It's an emergency, and this is the treatment. Don't confuse NMS treatments with tardive dyskinesia treatment. Okay. Done with that. Then now we're going to move on to non-pharmacological treatment of schizophrenia. So here now I'm not going to go into so much details here. So we're going to do, I think I just want to get the big things out of the way first, and then eventually like the exam is not going to be anytime soon. I mean, right now it's we're in August, and I'm not finished with the program until December. So I have time to study for the exam. It's just I like my notes to be ready, so that way I go over them over and over and over and over from now until December. But I have to have my notes ready. But if later on I'll come back and fill in more here, see. But I want to make sure these important things are taken care of. All right, meal, therapy. Okay. All right, general health consideration. Now look at this. Did you know that people with schizophrenia have shorter than expected lifespan? Okay, and persons with severe mental illness has prematurely loses 10 to 25 years of life. Isn't that crazy? Yep. Suicide rates are high. Always assess for suicide. And the key is with every visit, okay? Moving on a little bit here, blah, blah, blah. Of course, we have to involve primary care, lifespan. It's like more children. But how do you see it in children when the onset is 18 for men and 25 for women? So how is their children? I guess it's like the pre-symptoms. And of course, you got to follow up all the time with the doctor. Okay. Next here we have is Schizophreniform. Okay. So Schizophreniform. This one is simple, okay? It's not that complicated. Since we already know schizophrenia, that's not complicated. So the two things is, just like schizophrenia, except total duration is at least 1 month and less than 6 months. Okay, remember schizophrenia, it has to be 6 months or more. Okay, and the other one is does not require impaired social occupational functioning for diagnosis. Okay, so that's it. But it really has, oh gosh, Jesus, everything's falling apart. Sorry. Okay, so it has really the same, like here I'm looking at the book here. It also have 2 or more of the following, present which it within period of time, so same thing. All right, same criteria as above. Well, I meant to say symptoms, I guess. I don't know. I'm trying to make my words. I'm trying to say that it's the same as this. Where is it? Remember the previous video we were working on all of these? So yeah, it's really the same. Just the time period is different. And you don't have to have impaired social occupational functioning. All right. And it still have to have 1 month, by the way, but less than 6 months. That's the big thing here. All right. Next one is Schizoaffective. All right. So we're gonna put it here. This one is this is interesting how it's worded here. So it's uninterrupted period of illness in which the person experiences psychotic symptoms similar to those seen in schizophrenia, okay, as well as mood symptoms similar to MDD or bipolar disorder. See what I mean? So the key here is you have psychotic symptoms as well as mood on top of it. Isn't that crazy? That's hard. That's hard to catch. So that's why when you're diagnosing MDD and bipolar, you have to rule out psychosis. And when you're diagnosing schizophrenia, you have to rule out bipolar and MDD. Because if there's no MDD or bipolar, then you're just schizophrenia. But if you have on top of it also bipolar and MDD, then it's schizoaffective. Okay. Okay, 2 or more of the following. So it's, guess what? It's the same criteria as, same symptoms as schizophrenia. Plus 1 or more of mood disorders. And guess what? It can be MDD, watch here, as well as mood disorders, MDD, bipolar, or mixed mood episodes. Just plus 1 of these. So is it also 6 months or what? Oh, and the patient has to have delusions, hallucinations for at least 2 weeks without mood disorder. Okay, because if you're always having mood disorders and sometimes you get psychosis, then that I think puts it under mood disorder with psychotic features. But when you have 2 weeks without mood disorder, this puts it as schizoaffective because you're starting off with schizo. Okay, so you're mainly schizophrenia, but then you have affective on top of it. I think that's important. So presence of delusion or hallucination for at least 2 weeks in the absence of prominent mood symptoms. Okay. Okay. It has subtype. Okay, fine. 2 subtypes. Depressive, prominent mood, or depressive only. And bipolar, of course, prominent mood is sometimes are manic or mixed. Okay, cool. Treat it the same. And then you have delusional disorder. I like to put delusional disorder first because honestly, well, I think they have them in order. Because if you look at it at a spectrum, you start off with delusional disorder. Then you go to schizophreniform. Then you go to schizophrenia. Then it becomes more complicated, which is schizoaffective. So the way I look at it is really, delusional disorder is like, but anyway, delusional disorder. Now this one is presence of, watch this, presence of 1 or more bizarre, non-bizarre. Remember the bizarre and the non-bizarres? Delusions. Non-bizarre delusion lasting for 1 month. This is important. Daily behavior are not impaired, except as they surround content of delusion. Okay, except. Okay. So let me, there's another. But they don't fit criteria for skills. Okay. So that's that. And then now here they talk even more. Oh, here they talk about delusions. Remember how in the last video I had to look up all of this from the DSM-5. Well, and I was wondering why the purple book doesn't have it. Well, they do have it, but it's under delusional disorder. Okay, that's all right. Okay. So they're saying the difference here, the subtype erotomanic. Oh my God, I can't talk anymore. That you think someone loves you, but also it has, watch this, it focused on idealized or spiritual love and only infrequently has strong sexual content. Interesting. It can also focus on love of a famous, powerful person. It's that lady that was convinced that Michael Jackson loved her. And then we have grandiose, which is delusional, focus on the client having some great talent, skill. Okay, that's grandiose. This might have religious component too. See, that's interesting. So like you got spiritual love. Who knew this was part of that? I didn't know that. And then you have jealous, delusional content focus on false belief that client or spouse is being unfaithful. And then you have persecutory, which focus that on the client's belief that others are out to harm them, spy on them, or otherwise do them harm. So see here. Watched. Okay, like they are spying on me. Okay. This is the most common, I think. Right? Yeah, this one is the most common, according to DSM. Anyway, somatic now. I don't think there was somatic. Yeah, there was. Preoccupation regarding health and organ function. The body. Missing, etc. And then you have mixed delusion, which is really no clear, does not match types. All right, have somatic, persecutory, jealous, grandiose, erotomatic, mixed. Oh my God, we're almost done. And then we have brief psychotic disorder. Please tell me this is the last section in this chapter. I think it is. Okay. Brief psychotic disorder. Disorder with sudden onset of psychotic symptoms lasting at least 1 day, but less than a month. You see what I mean? It's a spectrum. Let me show you here what I mean. Schizophrenia spectrum. From least to more, like, complicated, you know. I think the least one is really the delusion, because when you have delusion, you don't necessarily have psychosis or anything like that. You have that delusion that you believe in. By the way, here, okay. So I think it's, oh gosh, don't ruin my spectrum. Delusional disorder. So it starts off with delusional disorder, and then it goes to brief psychotic disorder. I wish I can put it as a spectrum, but what I'm trying to say, it's like this is the order. And then you have this one. This comes after. And then you have schizophrenia. And then you have schizoaffective. Because schizoaffective is a little bit hard because it has both, you know? So yeah, that's my little... That's how I remember, I think. Because delusional is really just you lasting 1 month. You can say brief psychotic disorder is the least, because it's only 1 day. 1 day and less than a month. But delusional is lasting 1 month. You see what I mean? But the reason why I put it number 2, because it has psychosis. But delusions don't have psychosis. But anyway, you pick your own order. And that, ladies and gentlemen, concludes... Oh, one more thing, sorry. It's, I can't say it right. It's Folie-à-Deux, which means it's a cultural... Let me look it up here. Shared psychotic disorder. Okay. Folie-à-Deux. All right, characterized by development, delusion, person. Okay. So that a client is in close contact with a person who already has a delusion. The person with the delusion is the dominant, and eventually they impose their delusion on the other person. All right. Relationship is long-term and very close. And aside from the delusional contact, patient, or let's call him the client, behavior is otherwise normal. Okay, that's it. So this is when someone is following a person with schizophrenia. And I think this might gotta be the least one, because technically this person doesn't have anything, but eventually they will if they keep following this person. But that's it. That's schizophrenia. So I'm just gonna go over it, like pause the pages in case you wanna screenshot. So schizophrenia. All right, delusions, hallucinations, disorganized thinking, speech, grossly disorganized, abnormal or abnormal motor behavior, catatonia, and then you have your negative symptoms. And then a little bit about etiology here, genetic, neurodevelopmental, neurobiological, a little bit about the pathways here. The onset, how do you recognize it early? differential diagnosis, which is a lot. When do you hospitalize? This might be a question. Then you have treatment. Of course, you get your atypical. And then you get the rest of atypical. Okay, then you get your typical, and then some notes, and then your seesaws, and then your pathways, and then your EPS, and then your NMS, and then your non-pharmacological, and then you get Schizophreniform, Schizoaffective, Delusional disorder, brief psychotic disorder, and folie et deux. And then you have your spectrum. And that's it, ladies and gentlemen.